My name's Andrea Merriam. I'm the CEO of Parkinson Movement Disorder Alliance, and I am thrilled that you are choosing to spend some time with us learning about non-motor symptoms. We have quite the esteemed presenter today. But before we kick off, and while everyone's getting connected to audio and video and getting settled, I will begin with a few housekeeping items just to make sure we're all on the same page and we have good access to be able to hear and see. So today's program is being recorded and we will be uploading it to our YouTube and our website in about 1 or 2 days. And I mentioned that so you can really soak it in, be present, and know that you'll be able to access anything and rewind and play it back or share it with friends. Also, the slides that Dr. Isaacson will be presenting will also be available for download as a PDF if you want to refer back to those. And let's see, we have the closed captions and transcript option turned on today. So if you prefer to see the what the AI says that I'm saying in a subtitle across the screen, you can turn that on or off. Or if you find it distracting, you can turn that off, but we want to give you options. The way to control that, there's at the bottom on the menu, there's a CC live transcript button. So if you click that, then you can choose between all the options. And I can see that there's already some great discussion going on in the chat. We want today's presentation to be interactive. We want your questions, your responses to the material presented. As Dr. Isaacson's teaching us, if you have a question about how that relates to your specific symptoms or your loved one's specific symptoms, please put that in the chat. I will be collecting all of those and then moderating some Q&A after the formal presentation. And I always invite everyone to practice using the chat by typing in where they're tuning in from. And I must be a broken record because we already have folks who have shared even without my prompting. So hi, Bob from Carlsbad and Carol from Texas, Jan from the California deserts. It's all warm weather people. Oh, no, we have Sandy from Michigan, might be getting autumnal in Michigan, right? Well, we're here learning together. I invite you to say hi where you're tuning in from in the chat. It's great to know that we're not out there. Yes, we're in our homes, in our living rooms, maybe with our pajama pants on, but we're part of a bigger community here, the Parkinson's community at PMD Alliance. So welcome, welcome. And let's see, if you have any questions about any technology issues, anything stops working, we're here to support you. And my colleague Kelly is here. Can you wave, Kelly? Hello, hello. If you have any questions, you can either send her a private message or just put it in the chat to everyone, and she'll send you a private chat back with some troubleshooting. So if your audio drops or anything happens. Oh, and hi, my friend Gil from Macon is here. So let's get started. I will tell you a little bit about our presenter today and then hand the floor over to him to do some teaching. So we have the esteemed Dr. Stuart Isaacson. He's an associate professor of neurology at FIU. He's the director of the Parkinson's Disease and Movement Disorder Center of Boca Raton. And I don't know if this bio is up to date, but it says you've been the investigator on over 75 clinical trials. I wonder if that number has climbed. And Dr. Isaacson's a member of the Parkinson Study Group and the Movement Disorder section of the AAN. So welcome, Dr. Isaacson. And what is your current clinical trial number up to? Do you keep track of that, or there's too many?
Well, luckily for all of us, there's too many. There's so many, and there's so many new things happening nowadays that it's hard to keep track of. So we'll touch a little bit on that today, I think.
Thank you so much. If I know you have some slides prepared, so I'll turn it over to you to get going with the presentation.
Great. Well, thank you. I'm delighted to be back here with the Parkinson's Alliance here. This idea of trying to reach as many people as possible to give as much information as possible to improve, hopefully, the daily lives of everyone who's living with Parkinson's disease or affected by it. We have so much new research going on globally around the world, the meetings that are going on, the new drugs and also non-pharmacological therapies, and we'll touch on one of those today, are so interesting and so important to be aware of. And also important to recognize that without research, we don't find new things. And we can't do research to find new things unless people are involved. So hopefully we'll touch a bit on how you can become involved in some of these programs as well. I'll try to share my screen here and let's see. There we go. I think everyone can see my screen now. So what we're going to talk about today is some of the non-motor symptoms. And I know there's been a lot of talk about different non-motor symptoms over the course of a couple of years. Psychosis and orthostatic hypotension are often talked about as non-motor symptoms. We spent a lot of our time on motor symptoms and motor fluctuations, but today we'll try to focus on non-motor symptoms. And this is a picture that was first described by Bill Langston, who's out in California, in trying to describe the extreme focus that in the past we've placed on the movement problems, the motor symptoms. But really, that's just the tip of the iceberg that emerges above the surface, above the water that we can see. And there's so much more that goes on in Parkinson's and affects daily lives that's beneath the surface. And that's really what we're talking about today. A lot of the symptoms that we don't often highlight or focus on in the clinic visits and in research programs as well, although that's changing now. Just to let you know that Neurostim is a company, and we'll talk about one of the trials going on that they sponsor, and I've received research grants and consulting fees from them as well. But we're going to talk about non-motor symptoms and an exciting new research trial that is going on that you might want to know about and then think about becoming involved with. So the movement symptoms, the motor symptoms are so very common. We think about these almost all the time. The slow tremor in the hand that can occur, sometimes affecting other body parts, the slowness of movement. That's really the part and parcel of what we think about when we think about Parkinson's disease. The stiffness or rigidity and later problems with walking and balance. And these are so important. And we focus on these by giving dopamine medications, by giving rehabilitative therapies, by focusing on exercise, on staying moving, by using medications to help the benefit from doses of levodopa become more continuous and throughout the day and night. But there's a lot more besides motor symptoms that lie beneath the surface, if you will. And these are the non-motor symptoms that we talk about. So what are non-motor symptoms? Well, the name sort of implies that it's everything else besides motor. And that's sort of true, but there's a lot of things besides motor. For instance, psychological symptoms, anxiety, depression. Some people see hallucinations or delusions, these psychosis symptoms. Lack of motivation or apathy, memory or cognitive problems, even dementia, and these impulse control disorders. These we'll talk about each of these today. Autonomic problems. What does autonomic problem mean? Well, autonomic nervous system controls things that keep you alive, that we don't think about, like making sure your heart beats, making sure you breathe, making sure blood pressure stays stable, making sure food you put in your mouth gets out the other side over time in the GI tract, temperature regulation and sweating and the glands in the body, including the salivary glands. We think about the sleep cycles, circadian rhythms, vivid dreams, acting out of the dreams, feeling sleepy during the day, difficulty getting restful sleep overnight. And we think about other things, sensory symptoms like pain or tingling or numbness, eye problems, visual problems. smell problems, loss of smell. And we think about as well, not having the energy and having fatigue. It's really important to recognize these types of problems. This indeed is a survey carried out by the organization here that looked at how important are non-motor symptoms. And it turns out they're important. They're very important. Looking at over 500 people who answered a survey, this was actually published a couple of years ago. Many people find these non-motor symptoms to be equally or more challenging than the movement problems. And this is really mirrors a number of different research programs over the past 2 decades that have enlightened us doctors and nurses to really begin to focus on non-motor symptoms in addition to motor symptoms. And it's led to research programs and medicines approved for treating non-motor symptoms in Parkinson's. So it's really been a very important recognition for us. Indeed, in 2010, my colleague Ray Chowdhury and his group at King's College in London did a survey, and they realized that when people come to a visit with Parkinson's, they're not always aware they should tell the Parkinson's doctors and nurses about things like mood or memory or anxiety or pain or hallucinations or lightheadedness. That they had symptoms that weren't even talked about during these visits at an expert center, but were only found out when they went back and asked them to fill out a survey afterwards. So it's really important for us to not only recognize how important non-motor symptoms are, but also to figure out how can we get all the symptoms that are involved with Parkinson's disease treatment covered in a clinic visit, making sure you all keep the right list of symptoms, the most important symptoms, other important symptoms, other symptoms that are not important, bring them all in, have them make a copy, put it in the chart, scan it into the record, just so everything can be looked at. Some non-motor symptoms are part of Parkinson's disease itself. Some reflect side effects of medications, and many are due to Parkinson's disease itself and are made worse by medications. So it can be confusing to think about. So let's turn to some of these individually. There's a lot of information because there's so many non-motor symptoms. I'm not going to try to cover all of it, but to touch on some of the important points I like to discuss with my own patients that we see at our center here. And I'm happy to cover any of these in more detail as questions, and we'll have plenty of time for questions afterwards. So how about these mood depression? Well, a low mood, a depressed mood is an important symptom. It can affect daily lives and affect wanting to go out and do things and with family and friends and exercise and all. But it's important to recognize that it's a different type of depression than you might see advertised on TV. Some of the medications don't work as well, but we have some medications that can be more helpful. We have to make sure medications used to treat depression don't worsen Parkinson's symptoms. Most of the antidepressants that are used are fine for Parkinson's, but recognize that some of the new antidepressant medications that are added on, that are advertised on TV often, are really antipsychotics that can worsen Parkinson's. So some of the newer ones always want to make sure you're taking an antidepressant that doesn't worsen Parkinson's. That's not an antipsychotic that's being used to improve depression in people without Parkinson's. It's very common to have a low mood. And if you do, I encourage you to talk to your doctors and nurses about it. Sometimes behavioral cognitive therapy can help, counseling, talking to someone, letting off steam, exercise, getting better sleep, eating a good diet, minimizing stress, all these things can help. But sometimes medications are needed. And in this case, we have these serotonin reuptake inhibitors, the SSRIs, the SNRIs that can be useful, and other medications as well. Related sometimes to a depressed mood is anxiety. Anxiety is very important. Sometimes anxiety occurs with the movement problems when the benefit of a dose of levodopa is wearing down during an off episode. In that case, we treat the low dopamine, but many times anxiety occurs without any relationship to having the ups and downs, the motor fluctuations. And when that occurs, we have to think about treating the anxiety. We often treat them with the same medicines that we use for depression, because those medicines, the antidepressants, also help anxiety. Sometimes we have to think about using benzodiazepines, things like Valium, but we have to be very careful with those medicines used during the day because they can affect balance or thinking. We do use one of the benzodiazepines, clonazepam, though, to treat the sleep disorder of REM sleep behavior disorder, where people act out their dreams. Cognitive behavioral therapy can be effective, can counseling, but sometimes we have to use medications. Mindfulness, meditation can also be very helpful and is much more in vogue nowadays, and exercise is helpful, and getting good rest is helpful as well. Apathy is a big problem in Parkinson's because proper motivation in different pathways in the brain involve that same chemical dopamine. And low dopamine in Parkinson's results not only in a restriction of movement, but also a restriction of motivation, and it leads to apathy. We don't have good treatments for this. And most people with Parkinson's, when they don't have the motivation to do something, shouldn't go and do something that they have motivation for only, but go and do it anyway. Get up and go exercise anyway, go out anyway, walk down the street anyway, even if you don't have the motivation, because you don't want to have that double whammy where low dopamine affects movement, but also reduces motivation. So do it anyway. We don't really have a good treatment for this. How about psychosis? It turns out that hallucinations occur in about half of people over the years, the 20 years or more of Parkinson's, sometimes just in a hospital after an operation or after being sick with a urine infection. Sometimes they can really disrupt the day when people see or hear things that aren't true. We treat these either by adjusting medications for Parkinson's that are not necessary or optimized, but we don't want to cut back the dopamine drugs to reduce hallucinations, because then people can't move and they can fall. Instead, we want to have the right amount of dopamine medicines and add on a medication, an antipsychotic that's been looked at in Parkinson's that doesn't worsen Parkinson's symptoms. The only one approved in this country is pimavanserin that has an indication for approval for Parkinson's psychosis. Clozapine can also be used, and quetiapine is sometimes used off-label as well. All other antipsychotics should not be used because they worsen Parkinson's movement problems. How about memory and thinking? This is a big challenge. Sorry for my voice here. How about memory and thinking? Well, it's a big problem. One of the most common questions my patients want to know when they're diagnosed with Parkinson's is, will it affect my memory? And for most people, it will not. Dementia only occurs in people, probably about less than a quarter of people. Some of the numbers here are in other countries and reflect other populations. Most people have preserved mentation over the decades. Memory does worsen with aging, and it can worsen in Parkinson's. And some people have mild cognitive impairment, and some can develop a dementia, but most don't. We have one approved medication to treat this called rivastigmine. It comes in a capsule or a patch. And related medications can also be used as well. There are 4 ongoing trials right now enrolling for people who have memory or cognitive impairments or dementia and Parkinson's, so be aware of that as well. Compulsive behaviors occur mainly from taking Parkinson's dopamine medicines, especially some of the dopamine agonists at higher doses. Some of the newer medications being developed, including newer dopamine agonists, hopefully will have less chance of making this problem occur, these compulsive behaviors. We should be aware they can occur even in people not taking dopamine agonists. Let your doctors and nurses know if you have a compulsive behavior, that is binge eating, compulsive sex and gambling and buying. So if these things are happening, they can sometimes be addressed by adjusting the dopamine medicines or with cognitive behavioral therapy. Let's turn now to this problem with sleeping at night and not being sleepy during the day. It's such a problem. The circadian rhythms in Parkinson's are disrupted, and many people have this mismatch between feeling sleepy during the day and not being able to sleep well and get restful sleep overnight. It can sometimes be improved by Parkinson's medicines, and sometimes it can be worsened by Parkinson's medicines. So it's important to recognize that if you're having sleepiness during the day, it should be evaluated. So talk about it with your doctors and nurses. Make sure there's no sleep apnea. Make sure you don't have fragmented sleep from medications. Make sure you don't have restful sleep that's interrupted by REM sleep behavior disorder, where people act out their dreams, running and throwing and jumping in the dreams. And so we really need to be aware of this. There's some medications being looked at to try, and there's also some non-pharmacological things being looked at trying to help this as well. How about sleeping at night? Well, it can be hard to fall asleep and it can be hard to stay asleep. Two different parts of getting restful sleep overnight. Sometimes medications can help this. Sleep medications have to be used cautiously because we don't want to make people get up overnight when they use the bathroom and fall down because they're so groggy from a sleep medicine they took at bedtime. But there are some that can be used safely. There's some stuff being looked at in studies. There's also have to recognize that sleeping well at night and not sleeping during the day go hand in hand. The body will only need a certain amount of sleep, somewhere in most people between 6 and 8 hours in a 24-hour period. Any sleep you get during the day in the form of naps or falling asleep unintended will subtract from getting restful sleep overnight and can lead to a vicious cycle. So be aware that it may take a time to work with someone to really try to restore a better habit of using the bed just for sleep and only getting into the bed when you want to sleep, and when you're no longer sleeping, getting out of bed. How about other things that affect the autonomic nervous system? Well, saliva is important to chew and swallow food to make it moist so you can swallow it and to help begin the digestive process. And indeed, in Parkinson's, due to problems with the autonomic nervous system, less saliva is made in Parkinson's, and many people with Parkinson's have a dry mouth. Of course, the saliva that is made may not be swallowed regularly. Just like people with Parkinson's tend not to move as much as normal, tend not to blink the eyes as much as normal, they also tend not to swallow as much as normal. And saliva that is made can build up in the mouth, and it can spill out the front of the mouth, or what we call drooling. It can also spill to the back of the mouth and cause thick secretions and coughing, especially overnight or in the morning. We can now treat this with two medicines that have been approved by the FDA that are botulinum toxins. One is called botulinum toxin type B, and the other one is botulinum toxin type A. This slide incorrectly lists the brand name of one of the botulinum toxins that has not received FDA approval for treating this problem, but these other two have. Other people try to use medications, but these can cause systemic side effects and affect memory and cause constipation. So we tend to avoid them and use injections of botulinum toxins into the cheek, into the parotid gland, and underneath the chin to the submandibular gland. This can be done routinely. It's covered by the insurance, including Medicare, and is first-line therapy. How about low blood pressure when you stand up? That can make you feel woozy or dizzy, or even almost pass out or pass out. Well, this is due to a problem that's very common in Parkinson's and is due to a related brain chemical, not dopamine, but noradrenaline. Noradrenaline is made from dopamine. There's too little of it in the body in Parkinson's. And because of this, when people stand up, there's not enough noradrenaline to help the blood pressure stay up, and the blood pressure can fall with gravity. We tend to treat this by education, standing and squeezing the muscles in the legs and butt, and increasing fluids if there's no congestive heart failure, increasing salt as well. And some people wear compression belts. Some people wear compression stockings, but they have to go all the way up to the belly because that's where most of the blood goes when you stand up. There's not enough space in the legs. And then we have one medication that's approved for Parkinson's orthostatic hypotension that's symptomatic, called droxidopa, and two other medications that are approved for low blood pressure, for orthostatic hypotension, that can be used in Parkinson's, but weren't specifically studied nor approved for Parkinson's. How about the bladder? Bladder is a big problem for men and women. For women, the bladder problems that occur are due to aging, are due to childbirth, are due to medications, and are due to Parkinson's. In men, it's due to aging, it's due to prostate, it's it's due to medications, and it's due to Parkinson's. All of these problems, all four for men and women, come together to affect how the bladder collects urine and how it relaxes to let urine out. And when it doesn't work normally, you can be prone to infections, you can leak urine, you can lose urine. So when this is evaluated by a urologist, it's not a matter of saying this is due to Parkinson's or the prostate or the childbirth or aging or medications. It's due to all of them, a different part. And you have to treat the bladder problems often by doing different types of studies on the bladder to understand what the problem is. Is it overactive? Is it underactive? Is it not working in synchrony? And then there's a lot of medications that can be tried. You need to find a urologist who wants to try one medicine after another and not give up or get bored, because usually you'll find one that can be helpful. There's also non-pharmacological ways of trying to retrain the bladder, exercises, Kegel exercises, other types of pelvic floor exercises, and some stimulators that can be used for biofeedback. Sexual dysfunction is often ignored as well, but both men and women can suffer from changes in libido, uncomfortable or difficulty with sexual functions. This is very common. There are some ways to address this, and I urge you to talk to your doctors and nurses about it. You may need a urologist if you're a man, a urologist or a gynecologist if you're a woman, and really try to understand what is available and what can be used and how to safely use them. The GI tract is very much involved in Parkinson's. It may be where Parkinson's disease begins, with constipation and slowness of the movements, the bowel movements. Constipation is very common. And we have to think about constipation as being slow stool and also hard stool. So we want to soften the stool with stool softeners and fiber. We want to help move along slow stools with osmotic laxatives. And we also want to think about defecation. And it may be difficult to relax a muscle that allows the rectum to relax. And sometimes you have to think about how defecation is occurring and how the toilet is and needing a little stool there. So all these issues can be dealt with by either a gastroenterologist who's interested in Parkinson's and constipation, or by your Parkinson's doctors and nurses, and in forums like this. Not only the lower gastro tract is involved, causing constipation, but also the upper tract. And there can be motility issues in the esophagus, leading to the feeling that food or medicines are stuck. Make sure you wash it down with plenty of fluids. And in the stomach may be slow to empty, and food and medicines can stay there. This can lead to nausea or feeling full more quickly. It can also lead to the levodopa not working quickly enough. So some of these motor and non-motor symptoms can be interactive with each other. Temperature regulation can be affected in Parkinson's. Some people may feel hot all the time, some may feel cold all the time, and some may sweat. Sweating itself may occur when times of too much levodopa during dyskinesia, in which case we treat the dyskinesia. It can occur during off spells, and then we treat the off episodes. Sometimes it occurs with no relationship to the ups and downs of levodopa, and then we have to think about any triggers, other medications that can lead to perspiration, foods, and also to recognize that there's some investigational and off-label treatments that can be used to try to treat this. So again, talk to your doctors and nurses. We used to not think that Parkinson's can cause a peripheral neuropathy. We used to think it could not affect peripheral nerves, that it cannot cause pain. But we now recognize in some people, pain occurs due to Parkinson's. It can be pain from the brain, pain from the peripheral nerves, and it can also be an accentuation of other aches and pains that people get as they age. Arthritic pains and such may be worse in some people with Parkinson's, and it may be related to people who have a lot of stiffness and slowness. It may accentuate some of the pain as well. Evaluating the pain, thinking about different medications for pain can be helpful. So certainly if you're having aches and pains, your doctors and nurses who treat your Parkinson's should try to evaluate if it's related to too much or too little dopamine, if it's related to Parkinson's or to other causes, and then think about non-pharmacological ways of dealing with pain. And sometimes medications are needed as well. Along with apathy, fatigue is one of the most common non-motor symptoms in Parkinson's. Fatigue occurs, and fatigue can be hard to evaluate and to talk about. Some people have mental fatigue where they just can't concentrate and think, and some have physical fatigue where they just don't have that energy. When you discuss this, if you have this as a symptom with your doctors and nurses, don't confuse with feeling sleepy or drowsy. All right, this is not a drowsy feeling where you could fall asleep. There's a lack of energy feeling of fatigue. We don't have good medicines to address fatigue well. We always try to make sure there's adequate hydration, there's not relative dehydration. We want to think about getting the medications as even as possible and how they're being taken and how they're working. We want to make sure there's good sleep and good mood. And sometimes we have to try to just power through them. Sometimes caffeine can be of value. Medications do not typically help fatigue. The eyes are very important. We see things, and sometimes when the eyes don't coordinate properly and they're out of sync a little bit, you can see blurred or double vision. It could be hard to read for this reason, where the eyes don't come together to read or seeing in the distance. Some people have bifocals, trifocals, progressive lenses, and these can be very difficult for Parkinson's, people with Parkinson's, to coordinate the eyes to look through the different levels of the bifocals or progressive lenses. So many people with Parkinson's find that switching to two glasses, one for near vision and one for far vision, two different sets of eyeglasses, can resolve that problem that progressives sometimes don't. So that's a lot of information, a lot of non-motor symptoms. Hopefully you're not too exhausted to ask questions hearing all this information, but I wanted to give you an idea that Parkinson's affects much more than just movement problems. It's important to be aware that any symptom you experience could be related to Parkinson's disease, could be related to medications for Parkinson's disease, could be related to medications worsening symptoms that are due to Parkinson's disease. So talk to your doctors and nurses about it. Make a list. There's so many symptoms. Write down your list and put them in 3 columns if you must. The most important, other important ones, and other ones you have that are not so important. So you can prioritize what you talk about at your visits, but also make sure your doctors and nurses know, because if you have certain symptoms that are non-motor symptoms that are not very important to you, but they exist, your doctors and nurses might choose a different medicine if they're starting a new medicine, if you already have a mild non-motor symptom, because they wouldn't want to make that worse. So always keep an open dialogue with all these types of symptoms. Before we take questions, I want to tell you about a research program that's going on. This is exciting because we want more medications. We want more medications that work well and are safe and well tolerated, but we also want other things that are not medications. What do medications do? Medications help brain cells communicate with each other, often by adjusting the neurochemicals that help brain cells talk to each other and communicate. But the brain cells communicate with electrical signals, and they communicate through different pathways. And it turns out that you can try to modulate these pathways without medications by directly stimulating these pathways. What does this mean? Well, you might be aware sometimes you might hurt your shoulder and you rub your arm, trying to change that pathway's perception of the pain in the shoulder. You might have a headache and rub your back of your neck or your side of your head. Same type of idea. Some people have used other types of things over time where we try to limit tremor and in other conditions by stimulating peripheral nerves. Well, that's what this is. It's called neuromodulation. And this particular device looks like headphones you wear. This is in a case that helps them charge it. And by stimulating inside the ear canal, the nerves around the skin there and in the ear go into the brainstem, the same brainstem where we aim to try to make brain cells that make dopamine. That's where they live, in the brainstem. And it can modulate the abnormal signals that are in the pathways in the brainstem just by stimulating around the inner ear. What might this look like? Well, it looks like this. This is what it looks like. This is not available. You can't buy this. This is an investigational device that's being looked at in a research program going on around the country. It's regulated by the FDA, and hopefully it will show that it's effective in improving non-motor symptoms and that it's safe and well tolerated. And people wear this wear this twice a day for about half an hour or so. And if you look in the middle here, you can see that there's a little plug in the middle of where the ear would be, and that goes into the ear canal and gives a little stimulation there. And this stimulation is being tested to see how effective it is to improve non-motor symptoms, not just one symptom of apathy or low blood pressure, but all different non-motor symptoms. And it's being looked at by using a validated scale that looks at all the different non-motor symptoms, the ones I discussed and other ones as well, to see if it can improve non-motor symptoms. We're also looking to see if it can improve motor symptoms and overall quality of life for people who live with Parkinson's disease. So not a medication, but something that aims to do what's called neuromodulation. It's non-invasive. There's no needles or anything that goes into the body. This just stimulates the little ear where you might put a Q-tip if you think about it. And by doing this and wearing this twice a day for approximately half an hour, we're looking to see in this research program with different types of stimulation there, if we can improve non-motor symptoms and other symptoms as well. You wear it twice a day. It's actually 19 minutes, but about half an hour, twice a day. And then you put it back on the case so it stays charges. When you're wearing this, you can sit up, you can lie down, you can do other things, you can read or watch. The stimulation it gives modulates the brainstem pathways, irrespective of you concentrating on it. It just happens. It's something that we now know to happen. What's involved in a research program? Well, not everyone is lucky enough to be able to qualify for a research program. You have to give permission. It's called informed consent. It's usually 10 or 15 pages of information that tells you everything you'd want to know about the research program, and you have to talk to your doctors and nurses about it to see if it's right for you. And if it is, and you sign permission, you'll be evaluated to see if you meet the criteria of being eligible for the program, if it's safe to do so. And if so, you'll begin to use it and keep a record of what your symptoms are and be asked questions and have more contact with your doctors and nurses to see if this is effective. The information that's gathered is kept anonymous and not tied to your name. It's not part of your medical record. And it's kept and analyzed separately and anonymously so we can see if it's effective and what type of stimulation might be effective. And if it's found to be effective and safe and tolerated, the FDA will make a decision whether to authorize it and approve it to make it commercially available so that people with Parkinson's have access to it. This particular research program involves about 6 visits or so. Some are used a phone call or a video call. Some come into the center and it's done. And some important things to know is you have to have Parkinson's for this research program for at least 3 years. You have to be taking a stable dose of medications for the Parkinson's. You have to have enough non-motor symptoms that impact your daily life. You have to have a study partner that's around you at least 3 times a week so that we can get the information and see how it may be working. And after the 3-month period, then 8 months, they're going to let you use it in an open label extension. We use the treatment and we follow and see how it is without it and see with the treatment again to really understand the long-term usefulness and clinical utility of this type of non-invasive, non-medication therapy. So just to be aware that there are lots of studies ongoing, a number of studies that look at motor symptoms, a lot of studies that look at motor fluctuations or dyskinesia. There are studies going on with injections and pumps, but this is a study that's non-invasive, non-medication, non-pharmacologic therapy using a neuromodulator to stimulate in the outside of the inner ear canal and give that stimulation twice a day, 19 minutes each time, to see if it can improve non-motor symptoms and to see if it can do it in the short term, and then to see if it keeps working in the long term. So if you're interested in this, you can look on clinicaltrials.gov, and you can look clinicaltrials.gov. You could look at all the time and see the different research programs going on in this country and elsewhere for Parkinson's disease. It has, if you put in the search engine there, Parkinson's, you can look at the Michael Fox site that has the Fox Finder for clinical trials. If you're interested in this particular one, you can use this QR code and then find it. If you go to clinical trials and use that NCT code, that will bring up this particular trial. And here's someone who's modeling how you might wear this device over the ears and is reading a book and lying down while he's having this. He would do this twice a day for about 20 minutes. that's all the information. Hopefully you found it interesting and stimulating, and I'm happy to answer any questions that you might have about this or other things.
Okay, we do have some great questions. I'll start around DBS. Wondered, isn't neuromodulation another word for DBS? And can this device, could I be a part of this study if I have DBS?
So DBS involves neuromodulation via electrodes that are placed through the skull into the brain stem. So it's a direct neuromodulation that involves this placing of deep brain electrodes. This particular study, I don't believe, is enrolling people with DBS.
Very good. And
because we don't know if it's safe. We don't know if it's safe, so we'd have to know that first.
Okay, let's see. So there's another question. Okay, so Carol, liked your explanation of how medications affect brain chemicals, but pointed out you mentioned botulinum toxin for a lot of the treating a lot of the symptoms. So why was that mentioned so much? And can you talk a little bit about the mechanism of how a botulinum toxin works on so many of the symptoms that you taught us about?
So one of the chemicals that we talk a lot about is dopamine. We've also had medications approved recently that antagonize serotonin receptors for psychosis, adenosine and glutamate receptors for off episodes, glutamate receptors for dyskinesia. And there's medicines that work on acetylcholine. And we have a medication that increases acetylcholine to help memory and cognition and dementia in Parkinson's. And then we have some medications that block acetylcholine. And that's what botulinum toxin does. It works by blocking acetylcholine transmission, and that weakens the release of acetylcholine in muscles. It causes weakness. So people have overactive spasm muscles, it can make them less spasm. And people who are having a lot of saliva, by injecting in the glands, it reduces acetylcholine release that prompts saliva to be released. So it reduces saliva production. And it can be used in Parkinson's for dystonia as well, but it's only approved by the FDA in Parkinson's for drooling, not for these other conditions. Other anticholinergics that are taken by mouth sometimes are used in Parkinson's to treat tremor or for drooling, but you have to be aware that when you take anticholinergics by mouth, they could have systemic effects and affect thinking, worsen thinking, cause constipation, and cause a dry mouth.
Very good. And okay, so I'm going to combine a couple questions about cognition. So someone wondered about Parkinson's, dementia, and cognitive dysfunction versus Alzheimer's. And I'll try to combine this with the most recent question that says that a husband with Parkinson's often starts a sentence and never finishes it, and wondered if that is that, maybe a good example of the kind of cognitive dysfunction that can be typical to Parkinson's.
So there's no question that different cognitive issues can occur in Parkinson's. Sometimes we think about it could be related to medications or to aging or to Parkinson's, and they're interrelated. Some people have trouble remembering to sequence things and trying to take out the garbage and get the mail and then close the door may be hard, but doing one thing it can do. Some people have difficulty concentrating and getting a train of thought and have to stop and think about what was going to be said. Some of that is just attention. Or someone who may have trouble sleeping at night might have worse memory or thinking during the day. So it can be related. It can be related also to other medications. Medications for bladder sometimes block acetylcholine and worsen memory. So it really has to be evaluated. Now, clearly, someone could be unlucky and get two different diseases, get Alzheimer's and Parkinson's, but much, much more commonly, if someone had trouble with their thinking that was not due to a medication, not due to a problem getting restful sleep, not due to a vitamin deficiency of B12 that can be tested in the blood, not due to the thyroid problem, then we would think it's due to Parkinson's disease itself, and we would address that with medications that are available, already approved, or by research medicines being studied.
Okay. And another question, I'm going to combine two questions again, because you did a good job of answering that combo question. So someone wondered about whether they should go to a movement disorder specialist or another specialist for gastro or urological symptoms. And then someone asked any advice on the importance of having a team of doctors who all communicate with each other about all of these complex symptoms. What would you?
It's complicated. It's a big country, and it's hard to make a generalization of what's the best way to be treated. But the best way to try to approach being treated the best way is to have someone who listens to you and works together with you to get an answer. So if you have a rattle in your car and you bring it into the shop and they look under the hood and they do this and they try to fix it and they say, okay, I think I fixed it, and you drive away and you still hear the rattle and you go back to them the next day, you said it's still rattling, can't you find it? After a while, they can say, you know what, stop coming back, I can't fix your rattle, leave me alone. And you're gonna go somewhere else, or you're gonna live with the rattle. It's the same thing with these symptoms. If you go to a GI doctor or your Parkinson's doctor and they give up on your constipation, they try this or that, and you're still constipated, go to someone else. Keep looking and find out. Talk to people in groups like this where you exercise, and whoever, who has someone who wants to spend the time to try to fix constipation in Parkinson's, who wants to fix bladder problems in Parkinson's, that wants to deal with mood and anxiety and psychosis in Parkinson's, wants to deal with blood pressure in Parkinson's. It's not easy, but it's important to find someone. Sometimes it could be your Parkinson's doctors and nurses. Some centers have a nurse practitioner that does all that. Some have a doctor who does all that. Some send them out to different places. Some work in a big group of university where they have departments and one person each department knows. There's so many different ways and models. Whether everyone talks to each other is much less important, I think, than you actually get things done and get treated to get a benefit without having a side effect. In this day and age, it can be hard to get everyone talking. Team meetings you're not really going to occur with these people all over. And frankly, if someone goes to a urologist, I don't need to hear from the urologist who wants to start a medicine. I want to have a urologist that knows what medicines to start, is going to keep trying until they get a benefit.
Okay. And there's been a few questions about temperature control. Someone is asked if you could repeat again, what do you recommend if they are always cold? And then
Move to Florida.
Go to Boca Raton and become Dr. Isaacson's patient. And then Carol wants to know what can help with temperature control, such as sweats and chills.
So this is a problem with temperature regulation that's normally adjusted by a normal autonomic nervous system. In Parkinson's, the autonomic nervous system is not normal. So the temperature regulation won't be normal. So there's not much you can do to prevent that. If you're hot, have some way of making the places cold and getting into a cold shower or getting a cold pack over the face or a vest they sell these things. If you're always cold, well, do what I do when my wife keeps the house too cold and wear 2 sweatshirts walking around the house. Or step outside to warm up if you live in Florida or Phoenix or somewhere. But it's hard. You can't fix the temperature problem if it's due to Parkinson's because the autonomic nervous system is just disrupted. Now, sometimes it's not due to Parkinson's. Sometimes it's a side effect of a medication. Sometimes it's a symptom of a different condition, like a thyroid problem. So always bring it up and talk to your doctors and nurses to make sure that your thyroid was checked, that none of the medicines you take is causing this. And then you have to try to find out how to adapt to address it. Not an easy symptom.
No, I have two interesting questions. Bruce wondered if you think, or if there's any research that dry eyes might be a prodromal symptom of Parkinson's.
I'm not aware of research, but it's clearly it can be, because the glands that lubricate the eyes, the lacrimal glands, are innervated by the autonomic nervous system, much like the salivary glands are as well. And we know that in some people, the first symptoms are not GI-related constipation, are not psychiatric-related depression or anxiety, are not sensory-related loss of smell, but are autonomic symptoms with low blood pressure, or feeling dizzy or lightheaded when you stand up, or having a dry mouth, or even dry eyes, these types of autonomic symptoms. So it could be, but not commonly.
Oh, someone asked for us to explain what prodromal means.
Well, for a long time, we thought we diagnosed Parkinson's when it began, or shortly after it began. We now realize that we're late to the party. When you're diagnosed with Parkinson's, when doctors and nurses diagnose Parkinson's, we're probably 10 or 20 years late. Parkinson's begins that early, often without symptoms, sometimes with non-motor symptoms. Not until the motor symptoms come out do we begin to diagnose Parkinson's disease. So prodromal refers to before movement problems come out. Now, recognize we have some new advances that are really going to change how we think about Parkinson's in the next few years. For instance, we've had the DAT scan available, a brain scan that can look at dopamine in the brain and distinguish people who may begin to have low dopamine brain cells a couple of years before they develop Parkinson's. We have a skin biopsy that's approved by the FDA that can show that synuclein protein that's involved in causing Parkinson's degeneration. And that can be looked at in skin biopsies, or a punch biopsy over the shoulder, the thigh, and the calf. That looks at the synuclein and autonomic nerves. And this may become positive 5 years or more before symptoms we can diagnose now. And most recently, not yet approved, but being used in research, there's a type of assay called a synuclein seed aggregation assay or SSA that can look in spinal fluid and now looking at skin biopsies that might be able to detect synuclein even earlier. We also look at genes. Some people, and not most people, it's not genetic, but some people, probably about 10 to 20%, have a gene causing Parkinson's with or without a family history. And we can look at all the genes, and we can do this at no cost and anonymously through a variety of programs around the country now. So we have a lot of biomarkers that may allow us, especially in people who have a family history or who have a constellation of symptoms like loss of smell and acting out of the dreams, to look at some of these biomarkers and begin to diagnose Parkinson's during this premotor or prodromal phase, allowing us to begin to study ways to slow the progression and hopefully delay the onset of motor Parkinson's. And that's happening in real time now.
Okay. You mentioned loss of smell. Someone wondered about hypersensitivity disorder, and oversensitivity to smells is actually something this person experiences. Is that related to Parkinson's?
Yeah. Well, so we don't want Parkinson's that can accentuate pain and maybe other sensory phenomena, including hot spells and cold spells. But this loss of smell really seems to be part of Parkinson's. We've found that people who have a test for smell called the UPSIT, when they have more than a 15%, in the bottom 15 percentile of people with smell, they have about a 10% chance of developing Parkinson's in the next 5 years. If they have down below the 8th percentile, it rises even higher than that. So the loss of smell, it seems that Parkinson's degeneration affects initially the neurons that are involved in smell, the neurons that are involved in regulating constipation and gut motility, and the neurons that are involved in keeping dreams without having the movement involved. And those things happen earlier than the tremor and the slowness. And that those constellation of symptoms in certain people predict a very, very high chance of developing Parkinson's.
Right. Paula said she wondered about overeating as a possible compulsion. Said once her husband started Mirapex, he's been eating a lot. Wondered if that is, if you've seen eating as an impulse control, not just sex and gambling.
Yeah, certainly eating can be a compulsive behavior. It's hard to know where that range of normal ends and compulsive behaviors begin. But think about someone at an extreme who has a donut and has a second donut and finishes the box and then has to go out even at 11 o'clock at night to get another box of donuts. There's compulsion that to keep eating donuts, as opposed to someone who wakes up in the night because they can't sleep. There's not much you can do overnight. It's not a whole lot on TV. And you might eat overnight. That might not be a compulsion. That just might be out of boredom or not having other things to do. So it's hard sometimes to define. And there's some questionnaires that can help and specialists that can help.
Right. Well, I agree that everyone is saying this was such a great presentation. You're really good at these Q&A from all over. You were able to address everything, and we didn't get a chance to answer everyone's questions. I'm going to download this chat because all of these questions will make great fodder for PMD Alliance and future online presentations and online education that we put together. So stay connected with us. We want to teach you about topics that are crucial to you, add insight to the symptoms that are making your life difficult. So stay on top of our emails, and our programs team will try to work some of these questions into future presentations. And again, maybe Dr. Isaacson, could you put that QR code? That was an easy question. People missed the chance to get out their phones and scan that. Or Kelly, maybe you had it in the chat again, but people were perfect. Okay.
So if you go to clinicaltrials.gov and put in this NCT 04797-611, it'll bring up this program where you can use the QR code, and you'll be able to find this.
Thank you. Well, as you mentioned, participating in research is crucial. So if we want new therapies, new treatments, including non-invasive ones, non-pharmacological options, yes, participate in research, check out, see if you're a candidate for this trial. And thank you so much, Dr. Isaacson, for joining us and teaching us today. And thank you to everyone for your excellent questions. I'm going to take down the QR code and invite everyone to do a wave of gratitude to Dr. Isaacson, and just a little eye contact is good for the soul as we see everyone out there in our community learning together. So thanks again, Dr. Isaacson.
You're welcome. Great to be here with you guys again. Have a great day.